So let me turn it the next couple of slides over to my colleague Amanda. And Amanda, do you want to take over?
Yeah, thanks, John. So just a little housekeeping. We do have everyone on mute to keep background noise to a minimum. But if you have any questions or comments during the presentation, you can type your notes in the chat box. There's a little dialogue bubble there that should get you to the chat, and you can pose questions throughout the presentation. If someone in the chat box doesn't respond, we are keeping track of those questions. So we'll be addressing them at the end of the presentations in the Q&A. And then the other thing that we wanted to bring your attention to is that we're actually starting a learning network on this topic, writing better notes for patients. So if you're interested in joining a collaborative on strategizing how to do that better and thinking about practical ways to implement better strategies and best practices, get in touch. It's still in development, and we're building that now. So you can send me an email. My email's on the screen, and just let me know that you're interested in being a part of that. John, did you want to speak to that a little bit as well?
Yeah, sure. Thanks, Amanda. Yeah, this is a topic we think there may be widespread interest in, and think that a 6 to 9 month effort involving folks who are especially interested in it could result in some interesting ideas and interesting strategies going forward. And we have funding to facilitate that kind of discussion, and so want to put this topic out and see how this audience responds. And if there's interest in doing something of that sort, we'll get back to you with specifics.
Yeah, so please email me, and this slide will appear at the end too with my email address.
Well, so this has been a topic that I think intrigued us the whole time. As most of you know, our research did show that this is the workflow issue that is significant when in an OpenNotes implementation. About 15 to 20% of clinicians on average report that for at least a 4 to 6 week period of time, they need to adjust, make various adjustments in terms of documentation. In some places, this is more of an issue than others. In some places, they're very well prepared for this because they're aware of some of what you're going to hear today. And in other places, this is a struggle. So we're thrilled to be talking about this issue today, and we have 4 speakers, next slide, who have unique experience and advice for us. Our first speaker will be Jared Klein. Jared is at the University of Washington. I will forever be grateful to Jared for the paper he wrote in the American Journal of Medicine about tips for writing better notes. It's the publication I send out to implementers on a regular basis, and the publication that they seem to consistently appreciate. It's been very helpful to get folks to look at these issues and do things from the start at the implementation. The second speaker will be Leonor Fernandez. Leonor is from Beth, Israel. She's a practicing internist, and her focus is on vulnerable populations, lower income, and non-English speaking folks, and she's going to talk to you about the research she and colleagues at OpenNotes have done around writing notes for that population. Our third speaker will be Jeremy Warner, who's an oncologist at Vanderbilt, and I think you're going to hear some very interesting information about the research in terms of communicating in an era of transparency specialty information and tricky information when it comes to cancer. And then Steve Dobscha will be our final speaker. Steve and I go way back. Steve comes from Portland, Oregon, from the Portland VA, and he's been involved in and aware of and doing research on OpenNotes since it was implemented at the VA in 2013. And he really has a complete and wonderful cycle of work. I think he has 9, maybe 10 publications out there that really go from showing how nervous this transparency makes mental health clinicians to resolving that anxiety through some very interesting web-based courses he's developed. And part of that is giving them advice about writing better notes. So with that, let's go. And Jared, I think you're up first.
Thanks so much, John. Can everybody hear me okay? Great. I'm an internist in Seattle at University of Washington. I practice at Harborview, which is the county hospital here. And I had the pleasure of kind of helping write this article in the American Journal of Medicine a few years ago, and can't take complete credit. I had a big group of folks that basically came together with some suggestions. They're not all data-driven necessarily, mostly just expert opinion. And I think that the other caveat I wanted to share was just that I don't necessarily personally utilize all these suggestions. I think you have to see what works best for you and in your own practice. But I wanted to highlight the 7 things that we talk about in that article with a few examples. The first is, if you could advance the slide, thanks. The first is to be clear and succinct in your documentation. Some potential ways of doing that are moving the assessment and plan to the beginning of your note, just because that's really the meat of the note for your patient, and having it first kind of emphasizes it. Especially with EHRs nowadays, there's so much of this note bloat and this imported data that really isn't particularly helpful, and it's usually available elsewhere in the chart, both for clinicians and for patients to review. So avoiding duplicating it can help make the note more easy to read. And then I think this is challenging, but avoiding some of the jargon that we're frankly trained to include. There are some electronic tools. I know the EHR that I use, you can type abbreviations that the EHR automatically kind of converts into written out terms. So the second tip would be directly and respectfully addressing concerns. And there are other speakers today that address some of these exact issues. I have to credit for this first bullet Sigal Bell, who's one of the folks who's really spearheaded the OpenNotes movement. She kind of came up with this catchphrase of discuss what you write and write what you discuss. Whatever occurs in the visit should really be what's written, and ideally there would be nothing more, nothing less than that. I think some of the challenging areas that we run into are around the sensitive subjects in our society, obesity or substance use or mental health or intimate partner violence. And whenever discussing any of these, I think it's important for us to remember that HIPAA generally guarantees patients access to the information. It's not that by not including it in an open note, that patient is still able to access the information. It's just that OpenNotes facilitates that access, makes it a little easier than going to the release of information office to obtain the note. Even before OpenNotes are implemented, patients can see all the same information in their charts. So, thinking about the language is so important to a lot of the communication that we have with our patients, and that's true both of the verbal communication in the room, but I think the same is true for written communication in chart. And I think that there are fairly simple things we can do. We have to kind of untrain and retrain ourselves to do it, but thinking about instead of saying the patient refuses X, Y, or Z treatment, saying that they opt out of a treatment, reporting that the patient, instead of saying they deny alcohol use, you could say the patient does not consume alcohol. Some of these things don't take a lot longer to type, but we just have to get used to that slightly different way of expressing ourselves in the note. Some of the abbreviations like SOB or FU for follow-up, I think could be potentially confusing or problematic for patients, and so taking that extra minute to type that out could avoid some issues down the road. So the next tip would be to include patients in the note writing process. This is one that I find pretty challenging because I don't always do my documentation in the room, but I do generally try to angle the computer so that both the patient and I can see the data and the information there. When dictation is available, if it's available at your institution, you can consider dictating with the patient present. More and more institutions are sometimes using scribes, although that's not available to me. But I think that's another opportunity to kind of engage the patient in the documentation process. And then there's increasing interest in this idea of inviting the patient to contribute to the note. There's kind of an initiative called Our Notes, which we use a little bit, that the patient can kind of start some of the interval history of the HPI prior to the visit via the portal, and then you can import that into your note and kind of incorporate it into the HPI. I think this is really important in order to help patients and help patients get more out of OpenNotes, but also to help yourself get feedback about the notes, just reminding patients and encouraging them to read their notes. Just a quick mention before the end of the visit that I'd like you to look at my note, make sure that we're both on the same page. There are also kind of more systematic things that it's maybe hard for an individual clinician to do, but some EHR systems will have reminders either on an after-visit summary or automated EHR reminders to patients. Oh, your note is now available to read, and kind of prompting them to log in and look at that. I think those can be quite helpful to really help patients get the most out of the notes, and then also allow you to get feedback, like I mentioned. The second to the last tip is to ask for and use the feedback from your patient. So I think phrases like, did you have a chance to read my note from the last visit? Did it prompt any questions or concerns? Or, you know, we're working together as a treatment team. Let me know if you think there could be a mistake in your note. I want to work with you to fix it. It kind of aligns you with the patient, because ultimately that is the goal, to help them improve their own healthcare. And finally, the last slide is just being familiar with how to, or the last tip, excuse me, is being familiar with how to amend notes. I think we all recognize that we're human and errors occur. There are also times that there are disagreements that aren't necessarily an error, and I think those are different situations and should probably be addressed differently. In the first example here, there's just a frank mistake. You know, the wrong side of the body was mentioned in the note, and you could presumably correct that in the chart or correct it for the next visit if you don't want to do it retrospectively. There are other situations where, you know, you shouldn't necessarily change your medical assessment, like this example with alcohol. I'm sorry, you disagree with my assessment that alcohol contributed to your fall. While I can't change my medical opinion, if you'd like, I can add that you disagree with it. And taken to the extreme, there are situations where the patient actually might want to request to have his or her own, opinion or perspective included formally in their chart. And most medical record systems, most health systems allow that to happen with some kind of administrative process. So those are my 7 tips. And I think I'm really interested in the Learning Collaborative or Learning Network, because these are things that we kind of came up with as a group. I don't think that they're the be-all, end-all, and I'm sure that a collective group could really help hone and potentially even come up with additional notes or additional note-writing tips that could be really helpful for clinicians. Thanks.
This is Leonor Fernandez. Wonderful to join you and to this terrific team. I think we've all heard at this point and read many publications that really support the idea that patients love being able to access the notes. And we know the positive feelings include, feeling more in control of healthcare, of your healthcare, feeling more confident about being able to adhere to medications, and then feeling more able to find errors in your care. Now, we also wanted to understand what patients might find not so positive from reading notes. And we wanted to understand that in part because clinicians were raising this issue that Jared nicely outlined in terms of being worried about offending patients. So what we did was ask. So next slide. What we did was through an internet-based survey of 3 health centers, the one here at Beth Israel Deaconess in Boston, it's an academic health center. We asked at University of Washington in Seattle, including a safety net hospital, and in Geisinger Rural Integrated Health System. We asked survey respondents how they felt. Basically, we asked specifically, did you ever feel offended by something you read in a note? And separate question, did you ever feel judged by something you read in a note? So we had almost 30,000 survey respondents, and here's what we found. So about 1 in 10 are telling us that yes, they either felt offended, judged, or both, 10.9%. Specifically, you see here, 7.9% felt offended, 7.4% felt judged, and more than half of them overlapped. Clearly, this is important, and we want to understand this, who's feeling offended or judged. So next slide. Some preliminary data, which we presented at SGIM, along with my colleagues. And what we found, one of the most predictive issues in the demographic was self-rated health. So if people felt that their health was fair or poor, they had pretty dramatically increased prevalence of reporting that they felt offended or judged by something. So as you can see there, there's over 20% of people who reported poor health who felt judged or offended. And then, and this group overlaps, people who say they are unable to work, employment status, felt more judged and offended, also over 20%. So next slide. We wanted to understand what was offending them and making them feel judged. So we did a qualitative analysis, and we're submitting this now for publication. So the overarching domains of what we found. So at the top in orange, you see errors and breaches. So the single biggest thing, above 20%, that made them feel that way is when we got it wrong, when we put something that was a mistake or inaccuracy in their view in the record. Breaches refers to when they felt that we somehow breached their trust, something that didn't meet the expectations of what they expected in a note from our behavior. More on that in a moment. Right, the labels is when we characterize them in some way, usually of their person, of their identity in some way, or close to their identity, in a way they felt was inappropriate or unfair. And on the left, disrespect referred to the fact that they found the tone or some of the content at times disrespectful. And then there were some assorted other themes. Now, if we go to the next slide, we'll see at a more granular level, because I'm sure many of you are interested in what specifically errors and breaches. So starting there, I mentioned that mistakes and inaccuracies, and these were the specific mistakes and inaccuracies that they thought were offensive. So it's not usually left or right knee for this thing. What offended them were things that were more close to somehow to their identity and to the relationship with their clinician. Did not happen in a visit, meaning that a physical exam, for example, was documented, which didn't happen, often because we're importing a copy and paste kind of boilerplate note while we're writing it. Rarely they alluded to feeling that the clinician lied intentionally. Often they talked about a diagnosis not being discussed. Sometimes this may be because we're importing a problem list. And so they wondered, why is my mental health problem being listed when I go to the podiatrist, for instance, and then confidentiality concerns refer to the fact that sometimes they shared something in what they presumed was a confidential private sharing with their clinician. It was never explicitly discussed, but they thought it was confidential, and then they see it in the note and they wonder why that level of detail is in there. So finally, for disrespect, they felt some of the tone we use is cold, but beyond that, they thought it was condescending at times. They felt that we weren't always reporting well what they said. So we're either misquoting them or didn't apparently hear something that they felt was important and should be in there. And then clinical language and conventions is interesting. Some of our language that Jared was just referring to is inherently kind of weird, I gotta say, just plain old fashioned and weird. And so when we say things like patient claims, as though it was a legal, claim or refuses or denies or endorses, or even quite honestly complains of, which is the bread and butter of what we say, it's kind of a strange construction when you think about it. And then there were other sort of things we say routinely, like well-nourished, that they misunderstood to think that we're sort of trying to slyly say they're overweight when that's just the regular way we typically say that. So next slide. There. This is, thank you, a word cloud, which I find often in one quick picture kind of conveys what you're trying to get across in terms of what patients tended to bring up in these free text responses. Most of these responses were like 3 words to a full paragraph, and these, we took the adjectives that came up more than 20 times, and you can see obese, incorrect, wrong, personal, sexual, upset, offensive, etc. Anxious. I'm realizing that I may have skipped the personal descriptors. Did I? I didn't say in the labels, I apologize, that obesity was one of the big ones. Gender and sexuality pronouns, often in our transcription, that gets messed up. Also when we get it wrong, but sometimes it's just our transcription. And then things like elderly. My favorite comment was a woman who wrote about a young doctor saying she was elderly. She was 60. She wrote insolent pup, which I thought was amusing. So, and other stigmatizing topics. So if we can skip to the next slide again, sorry. So take home points. The patients want what Jared said. They want the note to reflect the visit. They don't want a surprise. And they also want the visit to reflect the note, which is interesting. They want us to make sure we're talking to them about any new diagnosis, particularly any new diagnosis we're making. They want their perspective documented. And this is particularly important when we disagree, when we don't have the same point of view about something. They want to be respected by their perspective being somehow faithfully recorded there. And again, to summarize, the top concerns for patients were mistakes, not feeling heard, feeling labeled, this skeptical, judgmental idioms, and this issue of obesity and mental health diagnosis being mentioned, which in situations they found not as relevant. And again, all of this is not to mean we should change everything we're doing, but these are important things to guide us as to which situations we should think about. Their vocabulary, our idioms should evolve, and how we should talk about things in a note and in the office. So thank you.
Okay, great. Hi, this is Jeremy Warner. I'm at Vanderbilt, and like was said in the introduction, I'm a practicing hematologist oncologist and also an informatician. And so I'm going to talk a little bit from a data-driven perspective on OpenNotes in oncology. Next slide. These are just my disclosures. Next slide. So, why is writing notes in oncology difficult? Well, really, oncology is a big, complicated space. There are at least 150 common types of cancer and thousands more uncommon types. Cancer is a disciplinary specialty. So here I'm showing you sort of what we call the pillars of cancer care, some of which have been around for hundreds of years, some of which are relatively new. And this is, really pertaining to all the different kinds of treatment that can happen. In particular, one patient can undergo all of these treatments over the course of their illness. Next slide. And cancer is longitudinal. So, for patients with advanced cancer, this is showing what we call the cancer journey. So, there's this diagnostic period, then followed by a hopefully very long period of treatments, as well as an increasing need for palliative care, symptom management, and then eventually in the incurable setting, end-of-life concerns such as hospice. And during all this period of time, there are multiple treatments, there are responses to treatments, hopefully remission, inevitably progression, and complications of treatment, side effects, long-term issues that arise. A very complicated space. Next slide. So this is, you can kind of click through this. Yeah, so this is, something that we worked through a couple of years ago in a workshop, kind of just thinking about, what are the issues that a cancer patient might want to address, around the time of diagnosis. especially in the setting of precision oncology when there's genomic testing on top of everything else. And you can just see that there's a lot of issues that come up, and it's really no wonder that research has shown that that patients retain, at most something like 50% of the information that they're given at their first oncology visit. And so certainly the documentation of that visit would be really valuable for a patient to go back and understand. Of course, they also have the opportunity to see their treating clinicians multiple times and go over many of these aspects over time. But it's really, I think, to kind of lay the groundwork for understanding what the disease is, what's going to happen, what are the economic consequences, what is the time span that can be expected, the prognosis, treatment, side effects, and all that kind of. So I think, like some other sensitive areas, there have been barriers to sharing notes. And so, first of all, like I've already alluded to, what we're dealing with here often is life and death. And it's, cancer still has a stigma, not like it did 50 or 100 years ago, but certainly it's quite serious. The care process is complicated and notes are filled with jargon, just sort of inevitably. It's multidisciplinary, like I said. There is, unfortunately, a lot of bad news, but not all news is bad. And even when it seems to be, and an example of that would be a radiology report that might look like things are worse, but actually in the context, things are better. And that does happen. And then finally, cancer patients are prone to PTSD. I'm happy to discuss that more in the question and answer period, but there is some literature to back that up. Next slide. So, because of that, BIDMC, Beth Israel, where I trained, there was a delay in rolling out OpenNotes to the oncology department. And what that gave us, and what I'm going to talk about next, is actually an opportunity to do some quantitative analysis of how the character of the notes changed before and after this go live period. So the first thing that we did, okay, so I don't know if there's any way to move. Yeah, there we go. So great. So the first thing we did was actually look at words in notes in isolation and look at how they were related to each other and whether those relationships or pairs of words went up or down after this OpenNotes go live period. We were especially interested in words that might have a lot of emotional impact, terminal and hospice and incurable, and it turned out that actually those words, their use didn't really change as much as we'd expected, but we did certainly find that certain word pairs changed before and after, and we used this network visualization to kind of get at that, where the blue links are things that became more common and the red ones became less common after OpenNotes. If you advance to the table, great. So this just shows a couple examples. You see the word pairs with the top 5 there. 4 of them have the word distress in them. Now you might think that that's emotionally loaded. In this case, it's actually part of a quality improvement initiative to actually increase the use of distress screening in cancer patients. And so that's why you see that word increase quite a bit. As far as the words that decrease, or the pairs that decrease quite a bit, maybe we can't say too much more about that. 2 of them have the word home, 2 of them have check. This is really preliminary, but as you can see from those p-values, very significant changes, as statistically significant in the before and after periods. So then we've started to take this further, and instead of looking at words in isolation, which can only tell you so much, we've started looking at what are called n-grams. And so what those are is a series of n words up to and including an entire document, but usually smaller than that, so like phrases, sentences, things like that. And again, we analyzed the before and after periods with over 100,000 notes across basically 2 major provider types. You've got the clinicians and the physician extenders, if you will, nurse practitioners in this case, and between those 2, over 100,000 notes. Next slide. And so I read our paper, but just kind of some high-level summaries. What we found is that providers were different. So on the left there, what you see is someone who before OpenNotes was using many long phrases that were pretty consistent across their notes. And then after OpenNotes, they started using many more short phrases. So what that might be is someone who stopped using boilerplate and started using more tailored notes instead of using some sort of phrase that was copied and pasted. But on the right-hand side, you actually see the opposite is true for that provider. Next slide. This is a dendrogram, which actually clusters providers on how they used phrases in their notes. And what you can see on the left is the before OpenNotes period. There were a set of 8 providers that documented in very similar ways. On the right, you see that those providers actually scattered out into the dendrogram, so they diverged from each other in the way that they were documenting. So again, this is pretty early work. There's a lot more to do, but what we did find is that OpenNotes does have a quantifiable effect on provider documentation, looking at the before and after periods. And in particular, some providers become more uniform in their note writing, and others become less so. Right now, we're looking at things like readability, and then the content itself and how those change before and after. Thank you.
So I'm going to try to focus a little bit more on the mental health, what we might more relevant for mental health. Next slide. Next slide. Nothing to disclose. So as John mentioned earlier when we started, VA actually went live with OpenNotes in January 2013. So we now have over 6 years of experience with OpenNotes. And in contrast to most systems that I'm aware of, there's really no provision to block any notes, including mental health notes. And over the years, people have raised concerns about mental health care and OpenNotes, concerns about potential patient confusion or exacerbation of symptoms, and also issues around privacy and confidentiality. So what we did is we had a VA-funded study that had really 2 goals. One was to understand veteran and clinician perspectives and experiences around VA OpenNotes as relates to mental health care, and then also to develop really 2 training programs, one for clinicians, one for veterans, that would minimize unintended consequences of OpenNotes use in mental health care, but also hopefully optimize communication and collaboration. So what we did is we started out the project by doing a lot of qualitative interviews with veterans and clinicians, actually about 28 each, really trying to understand people's experiences with OpenNotes and actually get their advice and really develop some content that would go into the training program. And so one of the key findings from veterans is that reading clinical notes online can either strengthen or strain trust in clinicians. And it was really all about trust. And so it turns out that if you have a good relationship with your provider, if the patient and provider have a good relationship or a long-standing relationship, what you write in a note is probably not going to make that much difference. On the other hand, if the patient's more ambivalent about care or about you as a provider, then what you write in the note can actually be pretty critical. And so I listed just a few quotes here to exemplify a few of those findings. The first one, I'd like my clinician to take it seriously too, not just spit something out on paper and not proofread it. Did the clinician actually listen to me? It seems like a very different person written about in the notes at times. And now a more positive one. I like the way my clinician puts them in because he's very blunt and honest. He pretty much says exactly what I've said. And what I really like about it is that he also puts in there what we talked about and what I said I would do. So as I mentioned, we developed a training program. This is the one for clinicians. You are welcome to try that link at a later time to get access to it, but I can't guarantee that link will remain active. And I ask that for the next week, you not share that link with others because I need to use it at another talk in a week. So anyway, we developed the CLEAR strategy. So this is in the clinician training program. It's really just an acronym. And as you'll see, it really overlaps greatly with what Jared presented. Next slide. And I'll walk us through some of the things, again, that I think might be a little different or new. So connect the visit to the notes. Or really connect the notes to the visit. As Jared said, discuss what you write and write what you discuss. Be thoughtful about language. And so this has come up obviously in the other presentations, but I do want to emphasize that veterans really thought, and clinicians, that you should use language that mirrors how you speak with patients. You really shouldn't be writing in a way that you wouldn't have a conversation with the patient in the room. And in mental health care, that's actually quite possible. A lot of what we think and do and write about is not particularly technical. And the other thing is there's some terms in mental health, like somatizer or schizophrenic, that are very, very labeling. And so you can phrase things a little bit differently. You can say a person with schizophrenia, for example, rather than labeling someone as a schizophrenic. One of the things that I think is that you can really do in mental health treatment is to encourage patient strengths and progress. And so you can really balance problems, deficits with patient strengths and resources, and really document goals and progress towards recovery. So kind of a before example, it might be, I'm not sure the veteran will be capable of going back to work in light of her level of anxiety. Well, that might be rephrased to something like, Ms. Thompson continues to discuss her goal of returning to school next year. She reported feeling nervous about applying. We discussed her qualifications, including the classes she's already completed and her strong math skills. So I think kind of a little spoonful of sugar can sometimes help. And I think this is also quite relevant when you get into more difficult types of conversations you've had with patients, as well as challenging notes to write. And A in the CLEAR acronym is audience. Consider who may read the note. It can be pretty helpful to talk to the patient about the purpose of notes and remind them that there are multiple audiences. There may be billers. There may be legal issues. And I think what I want to convey here is really to be thinking about what details are critical when documenting personal or sensitive information. So I give an example here about a patient talking about an affair that his neighbor is having. Is that really necessary, the details of that, to be in the note? For one thing, you don't know who is reading the note. It may not be the patient, it may be the patient's spouse. On the other hand, you do want to include enough detail so that enough clinician can effectively assume care. And this general principle applies to trauma in general. You may not need to get into nitty-gritty details some of the time, but you probably need to provide enough information that a clinician can understand the seriousness of the event and the general experience the patient has. And finally, R is to show respect and to be professional. I already mentioned some of the terms used. We found that veterans, and I assume other patients, like it when their names are used. So instead of saying patient says this or veteran says this, you can say Mr. Johnson. And then also being attentive to preferred names or pronouns is important. I want to go back and also emphasize that the cut and paste, patients pick up on that really quickly. And so I think this is really getting back to the connecting the visit to the note. You can just put one or two little things in your note that were particular to what was discussed in that session. And that's very, very important to patients. And then challenging situations, again, you want to avoid having anything show up in the note that wasn't discussed in the session. Sometimes with a differential diagnosis, say, for example, schizophrenia, you can think in terms of a differential diagnosis. Share with the patient that you're not completely sure, share your thinking process. This can be quite helpful. And then, as I mentioned, include some hope for recovery as well when you're writing about what otherwise might be bad news. I think also when you're documenting sensitive information, it may be helpful to discuss with the patient what you're going to document. And sometimes the patient, you may be able to give them some input into what degree of detail you put into the note. I think Jared mentioned writing the note with the patient, and we definitely do that when sometimes there's more contentious interactions with patients. It takes a lot more time, it's more complicated, but really kind of writing the note together and talking it through is a strategy that can be helpful in particularly challenging situations. I would also strongly encourage you to reach out to colleagues or a supervisor to get advice on completing notes. And even though people often ask me for advice, I will also ask others for advice. And finally, what can really help orient? I think discussing the availability of OpenNotes through Blue Button, talking about progress notes, talking about how patients can use their notes, and providing opportunities for patients to discuss notes or ask questions. We know from our research that patients are very unlikely to bring up OpenNotes with their clinicians if the clinician hasn't brought it up first. And in our study, we also found that orienting patients to OpenNotes was associated with a 4 times increase in the odds of them actually reading their mental health notes in general. So if we want patients with mental health conditions to use OpenNotes, we really need to talk to them about it. And that's all I have. I have one more slide with references. I'm also happy if somebody emails me to send you a copy of a pretty detailed outline of our training program. Thank you.
Wonderful. Thank you, Steve.
Thanks, Steve. So let's go to the questions and answers. Couple of options. I think folks who have questions can raise their hand, and Amanda will unmute your phone, and you can ask the question in that manner, or you can put your question into the chat, and we'll queue those up in the chat. We don't have any questions or comments in the chat yet, so I didn't encourage you to use the chat during this period of time. I'll start by asking a question I've been kind of dying to ask folks interested in this topic, and that's, have any of you run into conflicts or struggles because of coding issues? Let me give you an example. I was presenting at a hospital about the implementation of OpenNotes and talking about the documentation issues, and an internist raised her hand and stopped me and said, John, I'm concerned that you're in conflict with our code consultant, who has told us that when we use the term non-compliant, they're able to use a higher billing code. Have any of you all, or feel free in the chat, or audience members, have any of you all run into that kind of conflict?
Am I audible?
Yeah.
Yes, ma'am.
We definitely found that in the survey. One of the things that came up a lot was this issue of, we're supposed to say when we use time for coding that more than half the time was spent in counseling and coordination of care. And so it needs that phrase in some fashion. Now, when that phrase was in there, patients reacted to that by thinking we're complaining that we spent more than half the time counseling. So, and yet that phrase, at least as far as I understand, needs to be somehow in there to code by time.
Anyone else with comments along those lines?
I mean, this is Jared. I haven't had that exact experience about the non-compliant phrase, but some of it seems a little bit like an interpretation of the coders, because the underlying issue is the same whether you use the term non-compliant or adherence challenge difficulty. But I agree, it's hard to kind of bridge those divides sometimes between the clinical world and the patient experience, and then the billing and coding kind of environment. So
this is Jeremy. So not so much for billing, but actually we found that some of the long n-grams were phrases that had been mandated by the hospital. For example, if a signer of a note was late, if it was an attestation of a note, they were required to put in this very long, sort of confusing phrase. And that's one of the things that went away with OpenNotes, because it was confusing to everybody, including the patients, to see this, this statement about the fact that the note was signed late in the chart. So that is driving some of the changes that we saw, actually.
Thanks, Jeremy. Questions? Anyone out in the audience have questions?
I actually have a question. This is Amanda. I was wondering if, because several of you talked about labeling and terms like different ways that people feel stigmatized or judged. I'm wondering if any of you have had personal experience with that in your practices and how you've addressed that when it's come up.
This is Steve. I'm not really sure how to answer that. I mean, I think that I've been, practicing for many years under the assumption patients will read my notes, but I can't think of a particular situation where I had a discussion with somebody about those terms. Maybe someone else.
I can raise something, which is I recall a patient, this is not exactly on point, but a patient who had something very difficult happen with a family member. And in order to support her and to remember it, I included it. This is around the issue of details. And it was shameful to her, even though it wasn't about her, it was about a family member. And she was kind enough to tell me later that she wished I hadn't included that. And so I learned that somehow I needed to put it, as many of you just mentioned, more in a more shrouded fashion, so that it would trigger me to remember, but not shame her or in her mind stigmatize her.
Right. We've got a question for Dr. Warner in the chat. I'm a consumer health informatics researcher who focuses on consumer health terminology, but also a rare cancer patient. Wearing both my hats on my head, I am curious. Are there portions of specific clinical documents that you, as an oncologist, consider immune from rewriting? Example, many patients in the support groups are very confused. Many patients in the support groups that I frequent are very confused by the term, quote, KI-67, unquote. Jeremy?
Jeremy wrote that he is having network issues, so we'll come back to that question. This is Liz Salmi from OpenNotes, and since I'm talking, I'll ask my question out loud. I wrote in the chat box, but I'll say it out loud. Just curious, for those of you at academic hospitals, which 3 of you are, what advice do you have for those who, other clinicians who are working with students and residents who might be starting the note? And are you doing anything special to check their note before signing off on that note? And also, how are you teaching future clinicians about OpenNotes to kind of grow up in this environment?
Hi, it's Jeremy. Can you hear me? I'm back.
Yes.
Okay, that's all.
Go ahead.
I'm hardwired in.
Go ahead, Jeremy.
Let me try to tackle both. So first of all, I mean, getting to what others said about if you say it, the way you say it should be the way you write it. And like, if I was ever talking to a patient about KI-67, I would definitely explain, what it is in layman's terms. And so if I'm explaining it out loud, I should probably be documenting similarly. That being said, a pathology report, which is something that you refer to, that is not a note that is a note to a specialist, right? Like, a pathology report is essentially commissioned by the cancer doctor to give them the highly technical details that they need. And then it's really up to the cancer doctor, the treating oncologist, to translate those findings into words that are readable both by other clinicians as well as patients. So, but plenty, exactly, and patients see it anyway, and also plenty of clinicians just copy and paste the path report right into their document. So that's not a great answer, but we have to preserve the technical details, I think, but also interpret them in such a way that the note is readable. And this is another kind of project of mine, we should get rid of our current paradigm of progress notes altogether, and have something that's more dynamic and linkable, like a wiki format, in which case you could have a glossary of terms, so that everything that's kind of weird or technical can be linked to, and you immediately get the full definition, whether internal or from a third-party website like Wikipedia. But enough about that. Come to our AMIA session that Liz and I will be speaking at to hear more about that. So in terms of the other thing about the academic medical centers, I think that's a great question. I think that I'm pretty sure that it's not part of the medical student curriculum, but it probably should be, that First of all, documentation in general is not part of the medical school curriculum, which leads to all kinds of problems, obviously. But documentation for the intent of transparency, both with colleagues as well as the patients, just has to be part of that curriculum. And how to do that, I'd be curious to hear from others from academic or other centers.
Hi, this is Gordy Schiff. I have a few questions. Can you hear me?
Go ahead, Gordy.
Yeah. First of all, this has really been great. I guess I'm hearing they're moving from sort of taking away the negative edge, right, all the pejorative words, to think, and we haven't really come very far on that. You know, already there's a lot to do, but how to turn the notes into something more positive that is part of education, therapeutic, building a therapeutic relationship. So I don't know. This is great, but it's just the beginning, really. And I think I'm sure you all would acknowledge that. I guess nobody said this, but I have to speak for the PCPs out in the trenches. Who has time for this? You don't want me to write follow-up or GS 14. I have to write it all out. Of course there's scribes, but short of that, we're really up against this other constraint. So I guess we could talk a long time on that. Let me mention another thing that has to do with, I guess, police used to keep dual reports. They used to keep the official report and then the unofficial notes of what was really going on or what do you really think is happening with the patient. I fear there's a little tendency for us to do that. I don't want to really write what I really think about the patient. I'll keep those notes separately. How do we do that? I heard some tips about how to do that in a way that's not too stigmatizing. And I guess the final thing I would just say is voice recognition has just got to be front and center with this. It's really come a long way. If you haven't tried Dragon Anywhere, it's better than the stuff even on the desktop for your phone. So just something to throw out real quick. I know we're running out of time.
Yeah, thanks, Gordy. This is John Santa. One thing I would say is I've been so impressed. I mean, I'm at the end of my career. I've already ended my clinical career and near the end of my administrative career. I have been so impressed working for OpenNotes how much is going on asynchronously that us old doctors had no sense of. I mean, in this world, people are thinking, they're reading, they're talking, they're doing all kinds of stuff when they're not at their doctor's office. And so you're right, this is an evolution that's challenging, but, I just don't see how we can do anything but dive in and keep at it. And ultimately, I think folks are going to get incredible benefits from this asynchronous world. And there's places like Mayo that are really, I think, doing a great job, and many of your places are. We got to do more of it. I think with that, I see it's 11 o'clock, and so we'll end on time. Again, appreciate you all coming. You see Amanda's email on the screen now. Email her if you are interested in participating in a learning collaborative. Further discuss and perhaps do some things related to this issue. And you'll be getting notice when the recording of the webinar is available, and I think the slides will be available. So thank everybody so much.
Thanks to our presenters. Thanks everyone for joining.